Mandy, Rickard. I'm the nurse practitioner with urology at SickKids. It's my pleasure to introduce Dr. Dos Santos this morning, who's going to give us a talk on an update on the management of complex bladder and bowel dysfunction in children. Any questions that you guys have, we'll try to answer as we go along. You can just type them in the Q&A. And then there will be a couple of polling questions, and the way that we'll do that is either type your answers in the Q&A or raise your hand and we'll tally them that way. Okay, go ahead.
Thank you, Mandy. Good morning, everyone. Thank you for joining us this morning. We're going to discuss the management of complex bladder and bowel dysfunction in children. I have no conflicts of interest to declare. And I am a medical urologist, and great part of what I do is manage bladder and bowel dysfunction. I am proud to help kids with their bladders, as bladder and bowel dysfunction has a major impact in children's lives, as you know. And today we'll have as panelists Varghese, who is a nurse practitioner at SickKids. She runs the urodynamics program, as well as the bladder and bowel dysfunction clinic with me, and Mandy Rickard, who is also a nurse practitioner at SickKids, who runs the posterior valves clinics and other clinics, as well as the bladder and bowel dysfunction clinic. So we'll start with the clinical case, and we'll go back and forth with the clinical case during the presentation, supported by literature, with discussion with current literature on complex bladder and bowel dysfunction. We'll discuss pathophysiology, red flags that we should never forget, investigations, treatment, surgical options, neurostimulation, and what is next in the treatment of complex bladder and bowel dysfunction. So first of all, how would you define complex bladder and bowel dysfunction? I would say that any patient with bladder and bowel dysfunction that did not respond to conservative management, meaning urotherapy or bladder retraining and constipation treatment for more than 6 months. Why does it matter so much? One may think that, well, bladder and bowel dysfunction does not cause a major impact in health, what is also not true. But to start with, wetting the pants is a devastating event for kids. This is a paper published in Paediatrics in 2006 when they rated the most stressful life events in school-age children, and wet pants in class was rated as the third most stressful of 20 life events when school-age children were asked to grade them, just losing for divorce, parental divorce, and parental fighting. But we know that bladder and bowel dysfunction also has a significant impact in the child's health, with potential recurrent urinary tract infections and renal scarring. This is a study published in 2016 from a subset of the RIVER trial patients. Actually, those were the controls. It's called the CUTIE study, when 181 toilet-trained children were followed for 2 years, and those were the ones in the RIVER trial that had reflux or not, and did not take the antibiotics. They were taking placebo. And what they saw is that in 2 years, the risk of having recurrent UTIs was 20% for children that had reflux alone, 35% for children that had BBD alone, and 51% for children that had both. And that's why it's so important that whenever we have bladder and bowel dysfunction in toilet-trained kids, to address this issue and not the reflux right away in children with recurrent urinary tract infections. When talking about bladder and bowel dysfunction, we should also always remember the red flags. I also always tell trainees, don't jump steps, don't jump the physical exam, because not all incontinence will be bladder and bowel dysfunction. For instance, in the presence of constant dampness in a girl with a duplex kidney, we need to think about a possible ectopic uter. Or if you have constant dribbling and an abnormal back exam, we need to rule out neurogenic bladder or occulted spina bifida. If you have in your history excessive thirst, weight loss, blurred vision, you need to rule out diabetes. If you have dribbling post void, you need to, and in a girl, you need to rule out labial adhesions, or in a boy, severe phimosis or BXO. So if you have a weak stream in a boy with constant dribbling and the ultrasound shows hydronephrosis, especially if bilateral with an abnormal bladder, we need to rule out missed posterior urethral valves. The most common types of voiding dysfunction in children we are going to address today: overactive bladder, dysfunctional voiding, stress incontinence, Giggle Incontinence, and Heman syndrome. That is not common, but is the most severe type of non-neurogenic neurogenic bladder that should always be ruled out. So our case is a 10-year-old boy with urgency, frequency, daytime incontinence, primary aneurysms and encopresis since age 5. So basically since toilet trained. Had a normal physical and neuro exam. He reached all appropriate milestones. He's very active and has attention issues that were raised at home and at school. He's gifted and had unsuccessful conservative management over those past 5 years. Has a normal renal and bladder ultrasound. So which initial investigations would you order? I'll ask you to please type in the chat. A uroflow with PVR, with post-void residual, video urodynamics, avoiding diary, a spine MRI, or both uroflow and voiding diary.
So they'll have to type their answers in the Q&A because the chat is disabled.
Okay.
You guys can just use the Q&A tab and I'll tell you the answers.
Okay.
Okay, so we're getting A and C, C, A and C, A and C, C, D, the voiding diary, A and C, D, voiding diary.
Okay, great. Yeah, so I would say that initially I would agree that I would order, sorry, let me stop here. I would order a uroflow and a voiding diary to begin with. And the reason is we need to find out what is the cause for the incontinence. Does this child truly has urgency and frequency, or he's an infrequent voider? What are the voided volumes as a first step? He'll occasionally and eventually get all of those tests, but that's an important first step. So this child is 10 and this is his voiding diary. You can see that in one day he voided 20 times and his voided volumes, the highest volume was, max voided volume was 30 mLs. When the expected bladder capacity for him, if you use the formula age plus 2 times 30 in mLs will be 360. So it's less than 10% his expected bladder capacity. Unfortunately, this is an incomplete voiding diary, which is reality. Most voiding diaries will come back incomplete, but it gives us so much information already. And he wets the pants several times in a day. Here is his uroflow. So he has a relatively normal bell-shaped curve, although in patients with overactive bladder, you may have the tower-shaped uroflow. And he voided 86 mLs, again, 1/4 of the expected bladder capacity with complete emptying. With that in mind, we know that this child has overactive bladder. Right? We don't know yet if it's a primary overactive bladder or a neurogenic overactive bladder, but for sure is overactive bladder, which is a clinical diagnosis. Overactive bladder is the most common urological presentation in the spectrum of bladder and bowel dysfunction in children. It is, though, multifactorial and in a complex diagnosis. So if you consider only the overactive bladder, only the top of the iceberg, and not all associations, you're basically treating a symptom and not a disease. So overactive bladder is very commonly, almost invariably associated with constipation in children. Children can have toilet training difficulties from the beginning, learning disabilities and ADHD, as well as other neuropsychiatric and behavioral disorders, extremely common. Obesity, social stress, genetics and epigenetic factors are also associated. And all of that needs to come in consideration when treating overactive bladder. It's a clinical diagnosis. It's basically an alteration in the filling phase of the bladder, presenting with urgency. Not necessarily the child will have frequency, incontinence, and nocturia, because children, they adapt, and they may stop drinking as much, or just ignoring the wet episodes. So those might not come very clearly in history, but urgency is always there. And to diagnose a child with overactive bladder, they should be necessarily toilet trained or after an attempt of toilet training around the age of 4 or 5. The intrusive overactivity is commonly present, but it's a symptomatic finding, so not necessary for the diagnosis of overactive bladder, which is clinical. The true epidemiology is hard to tell, and the reason is the large population studies, they look into daytime incontinence and not necessarily urgency, so we don't know, but most studies will say that up to 12% of children age 5 to 12, or 0.5 to 1% of adolescents will have overactive bladder, and usually they get better in 50 to 70% of the cases with treatment, not on its own. So as I said, children, the true prevalence is also unknown, because children may mask symptoms, and very commonly they stop drinking as much, or they avoid situations where the bathroom is not available, or they simply give up hope. So what happens in the overactive bladder is the detrusor muscle contracts prematurely, way sooner than it should. Typically, the bladder starts contracting when it's 2/3 full and reaches 2/3 of the expected bladder capacity for age. And in overactive bladder, you have 1/3 of the expected bladder capacity of urinary volume or less than that, and the detrusor contractions start. It's multifactorial, and recent studies using functional MRI and PET scan, comparing children with normal lower urinary tract and children with detrusor overactivity have been helpful to find out the role of the cerebral cortex and the brain stem in bladder contractions. There are also local innervation and molecular interactions that come into play, genetics and epigenetic factors. So this is a very interesting study published in Nature Review Urology from Dr. Franco a few years ago in 2016, that basically shows on your right and your left-hand side normal response to voiding, to bladder contraction in a child, and on the right-hand side, a child with detrusor overactivity. So the prefrontal cortex is responsible for decision-making, is our decision-making area, responsible for, emotional responses and social context, while the ACG, which is the anterior cingulate gyrus, is responsible for suppressing bladder contractions, and also the response to conflict, stress and conflict. So what happens is in a child that has detrusor overactivity, the ACG lights up, so it's overactive, while the prefrontal cortex is suppressed. That means that a child with overactive bladder cannot suppress the urge to urinate. And very interestingly, that those are the same areas affected in a similar way in children with ADHD. So it's not surprising to see that literature shows that 25% of children with overactive bladder will have ADHD, 8% will have anxiety, and almost 11% will have ODD. I would say that learning disability is even more prevalent than ADHD, with pretty much 40% of children having some degree of learning disability. We recently published this paper when we assessed the prevalence of neurodevelopmental and psychiatric disorders in pediatric bladder and bowel dysfunction. So we surveyed 61 children coming to clinic for bladder and bowel dysfunction without a known previous diagnosis, and they filled the SDQ, what's the Strength and Difficulties Questionnaire, and we found out that 23% of them who had will be flagged for a neurodevelopmental disorder, most of them being learning disability. It's more than 40%, and almost 30% ADHD. In regard to genetics and epigenetic factors associated with overactive bladder, we know that those children not only more commonly will have bladder and bowel dysfunction, but they are also more likely to be refractory to treatment. And this is important for counseling and to set up expectations with families that children will get better, but they might take more time and may need more treatment as well. It's also known that obesity is more common in children with overactive bladder. They are also at high risk for fecal incontinence and neuropsychiatric disorders. And this is applied to interactions between cortisol, the corticotropin release factor, obesity, and overactive bladder. And there is a greater likelihood of symptomatic patients with higher BMI having an overactive bladder and incontinence. Back to our child. So he had overactive bladder with the 10-year-old boy, but he also had refractory constipation with encopresis. So this child was 10 and is still on pull-ups for day and night for bladder and bowel. We managed his bowels aggressively with PEG, sinusides, magnesium, bisacodyl, and ultimately he was using retrograde water enemas, Peristeen, and with that he achieved 50% of reduction in soiling, but not more than that. So given that his bowels are optimized right now and he has persistent symptoms after 6 months, how would you treat his bladder? Would you use mirabegron at this point, oxybutynine, sulifenacin, or the Truser botox injection? Just have in mind that there is no right and wrong here, but I would like to start this discussion. So I hear oxybutynine as first choice, mirabegron, oxybutynine. Okay, yeah, so I would say that oxybutynine is the first drug, the first available anticholinergic, the first to be approved in children. However, we'll discuss that a little bit further in the slides. Given the severe constipation of this patient, and the fact that he had a normal physical exam, a normal blood pressure, no cardiovascular conditions, we opted to start him on mirabegron first. So in regards to the medical treatment of overactive bladder in children, we have 6 marketed anticholinergics approved for use in children by the FDA or Health Canada. The ones available in Canada are oxybutynine, propyverine, and solifenacin. And we also have mirabegron, which is not an anticholinergic, so is a beta-3 agonist that works similarly in the bladder, relaxing the detrusor, increasing the bladder capacity, and decreasing the detrusor overactivity. The issue with anticholinergics is that the potential side effects associated with that commonly lead to discontinuation of the medication in up to 10% of the cases. Side effects such as blurred vision, dry mouth, headaches, constipation, make it difficult to treat, especially in the context of severe constipation. Right, many studies have shown that oxybutynine is not as effective or as efficient to treat overactive bladder in children than other anticholinergics that have been proven superior, such as solifenacin, trospium, and others. So a relatively recent study, it's a prospective study using solifenacin in children with refractory to oxybutynine, showed that it improved capacity and also decreased inhibited contractions. Another thing to have in mind are the potential central side effects associated with oxybutynine and anticholinergics. Studies have shown even that oxybutynine has substantial more side effects in the central nervous system than trospium and tolterodine in adults. When you Google oxybutynine, and the concerns are all associated with dementia as well in the future, and really don't know what is the impact in children using oxybutynine for years and years. Oxybutynine is not a selective anticholinergic, so it reaches M1 to M5 receptors. M1 receptors cross the blood-brain barrier very easily. And it's interesting to hear from families that once they stop oxybutynine, they can see a change in behavior of children. This is anecdotal based on my experience, but in keeping with what we have been seeing in recent discussions in the literature. This is a discussion published in JAMA in 2015 about the cumulative use of strong anticholinergics and incident of dementia in elderly. So 3,400 patients with more than 65 years without dementia were followed by for 10 years. And there was indeed a higher cumulative anticholinergic use as an association with increased risk for dementia in that population, which is quite scary. This is the paper that I briefly mentioned about from Dr. Baldock, studying the long-term use of Solifacin in pediatric patients with overactive bladder that have shown basically, this study has followed almost 250 patients that used Solifacin with a significant decrease in inhibited contractions and increased systometric capacity on urodynamics. There was also an overall 91% decrease in daytime wetting episodes, what's quite remarkable, more so for non-neurogenic diffuse overactivity. And this is a second study also from Dr. Baldock's group. It's a prospective pilot study of mirabegron in pediatric patients with overactive bladder. The cohort is a bit smaller, 44 patients, but it's also proven tolerable with a significant increase in maximum avoided volume and decrease in wetting episodes. This was, I think, a 58 patient cohort, and 8 of them had mild side effects. None of them had hypertension, which is a potential side effect in adults and children with baseline cardiovascular conditions. When things do not go well with monotherapy, one thing that we can do is associate both mirabegron and an anticholinergic. And this is a prospective open label study showing results involving 35 patients over 10 years. What was seen was an increase in the expected bladder capacity from 50 to 74%. Continence improved in all patients. 12 were completely dry. The post-void residual was increased in only 2 patients, and 1 had a UTI. So this is a feasible and safe option for refractory patients as well.
Dr. Dos Santos, we have one question that maybe we can hear.
Sure. Yeah.
And so it says, in adults, you have to show that you've had an unsuccessful trial of oxybutynine first before you can get limited use coverage for new anticholinergics or mirabegron. Is this also true in children, or can we just jump to mirabegron in patients with overactive bladder in the setting of BBD?
That's a great question. I would love to jump directly, but we do need to prove that oxybutynine failed for coverage with the LU code 290, or in the case of this patient, when we have a severe refractory constipation, you can use it as well, because an anticholinergic will be contraindicated. Okay. Another option, so we discussed monotherapy. When monotherapy fails after optimizing combining meds, and a non-medical option for refractory cases will be the Truser Botox injections. One study from Dr. Lorenzo in our group has shown more compliant bladder with reduced pressure, increased bladder capacity, and improved degree of urinary continence in those patients. But there are current clinical trials investigating the use of Botox in overactive bladder now. This is a study in adults published in JAMA in 2016 with women with refractory urge incontinence comparing botox versus neuromodulation. With botox, there was a slightly more significant decrease in incontinence, but they were at higher risk for urinary tract infection and transient need for catheters with the urinary retention. So neuromodulation in that sense was superior, and we don't have such a trial in children yet. So back to our patient, what did you do? How would you treat his bladder now? So we treated him with mirabegron. We started with minimum dose 25 milligrams. Then I'll tell you guys the story. We increased to 50 milligrams, which is the maximum dose. He still has symptoms, he still has incontinence with significant urgency. Then we associated solifenacin up to the maximum dose of both mirabegron and solifenacin. And here we are. He is still wetting his pants. He still has soiling every other day despite peristeen. We did a urodynamic study. His systometric capacity is decreased at approximately 170 mLs. So improved, but not great. One should be 360. He has the true overactivity and he leaks. We did a spine MRI. So as I said, we end up doing all studies in the first question, and the spine is perfect. But look at his rectum; he's so backed up, despite all treatments, the aggressive treatment of his constipation with maximum dose PEG, stenocytes, magnesium, and the retrograde enemas. So we are intrigued with that. Why is his constipation so bad? And at this point, obviously GI is involved, and we did all possible screenings for celiac disease, hypothyroidism, and also a GI transit study. And his GI transit study was relatively normal, except for retention of activity in the rectum, in keeping with functional anorectal retention. So we have now our kid that has refractory overactive bladder and encopresis despite combined therapy and peristeen. What we offered for him was neurostimulation, right? So I would like to talk a little bit about the literature on neurostimulation for patients with refractory overactive bladder. This is a study, it's a meta-analysis of 5 RCTs in children, and this study showed that neurostimulation may lead to better partial improvement of a non-neurogenic overactive bladder, however, not a definitive complete response in those studies. If you choose this study, look into sacral neurostimulation and also TENS, what is transcutaneous neurostimulation. And for TENS, office-based neurostimulation seems to be more efficacious than self-administered TENS at home. But further RCTs are needed to compare both regimens. In regards to sacral neurostimulation, we have several studies over the past 15 years showing that SNS has high efficacy and is safe for refractory severe overactive bladder. A study of 20 prospectively followed patients with bladder and bowel dysfunction reported a cessation of symptoms or complete improvement in 20 out of 100 patients, and more than 50% improvement in almost 90% of the patients. And this is for bladder and bowel. So this is consistent with pretty much all studies that I saw. 80 to 90%, 94% improvement in at least one lower urinary tract symptom, up to 90% improvement in incontinence, frequency and constipation, and so on and so forth. So it's very consistent with all studies. And even a decrease or wean off of medications as anticholinergics or alpha blockers with the use of SNS. As importantly, one study showed significant improvement in psychosocial and quality improvement scores, quality of life scores. This is an interesting study on sacral neurostimulation used for severe constipation, showing that, so this study followed 22 patients with severe constipation that actually had a MACE or a cecostomy tube for management of severe constipation. And what they saw after 12 months of follow-up is that there was a decrease in the use of MACE from 7 days a week to once a week, what is major, huge. And 10 of those patients, or half of the cohort, could take down the MACE after the use of sacral neurostimulation. And to be honest, that's what we see in practice. We, over the past few years, we started our sacral neurostimulation program, and we did 5 children so far. And the response for the bowels is striking. For the bladder, yes, it improves, but I could not take any of them completely out of medication yet. But for the bowels, constipation improves from day and night. It's a significant difference. Another option will be the percutaneous neurostimulation with TENS, which use patches in the back, just near the sacral nerves, S3 and S4, or you can use this one that you have in the photo on the left side, which is PTENS, the pretibial neurostimulation, and that's an office-based neurostimulation modality. And these studies so far have shown variable results with TENS, but apparently TENS is significantly better than PTENS for resolution of incontinence. In our child, he has a sacral neurostimulation still. He was implanted in 2019, so now it's 2 years. And in 2 years, his DVSS, with the voiding dysfunction score, dropped from 16 to 4. So he no longer wears pull-ups, what is major for him. He no longer needs peristeen. We are weaning him off his meds, so he's currently only taking Solifacin, no longer takes mirabegron. And the quality of life scores, his caregiver scores improved from severe to moderate, and he dropped from moderate to mild most recently. So I would like to summarize overactive bladder. It's a complex multifactorial syndrome that can be carried to adulthood if not treated. Epigenetic changes such as obesity and stress also play a role in pathogenesis. And there is currently continued research in the role of the frontal lobe and the brainstem to better understand the central processes involved with overactive bladder. And currently ongoing clinical trials on new medications, botox, and neurostimulation associated with genetics and epigenetics that will hopefully help us individualize the treatment for those patients. Now I'd like to move on to dysfunctional voiding, which is an also common type of voiding dysfunction in children. So the pathogenesis is different. Those children, they are not able to relax the pelvic floor muscles and the external sphincter appropriately during micturition. And with that, as you can see in the right-hand side in the VCUG, especially girls can have what is called the spinning top urethra, which is suggestive of dysfunctional voiding. In the bottom, you can see uroflowmetries with EMG. You see that during the micturition, you have increased EMG activity in a child that has dysfunctional voiding. They typically present with abnormal stream, interrupted stream, dribbling, pelvic pain or dysuria, recurrent urinary tract infections, and a high post-void residual. So it's important to diagnose this because starting those kids on anticholinergics or mirabegron will make it worse. We increase their post-void residual, they end up in urinary retention. So that's why whenever we get to this point with complex BBD, with children that did not respond initially to the treatment, it's important at a minimum to get an ultrasound with post-void residual if a uroflow is not available. We have participants participated on bladder and bowel dysfunction guidelines recently. One at the top of the page is the CUA guidelines for the treatment of BBD. And in those guidelines, we included only RCTs up to November 2019. The bottom guidelines are the CPS, Canadian Pediatric Society position statement, that both are similar. And the caveat of the CUA guidelines that are included only RCTs. I summarize the recommendations here. So in regards to bladder retraining, we know from RCTs that using a timer, using a watch is superior than just reminding a child to go. Right, so it's worthwhile invest on any sort of alarm. Does not need to be a vibrating watch, but the timer in their phones or laptops now that most of the kids are doing online school. The second point is that face-to-face counseling or education is as effective as group or individual or video instructions, which is so relevant right now in the COVID era, right? So we can do most of the BBD appointments virtually, and that's effective. In regards to biofeedback and pelvic floor physio, both are great options in only 2 scenarios according to the RCTs, underactive bladder and for dysfunctional voiding. So especially for dysfunctional voiding, biofeedback has a positive effect on reducing daytime incontinence and post-void residual. What is the evidence around TENS? So TENS may be useful for, again, the management of overactive bladder and underactive bladder. It was not proved helpful for other types of voiding dysfunction. And RCTs available for the study of anticholinergics in overactive bladder have shown that Solifacin, propivorine, and tolterodine all decrease incontinence episodes and increase maximum voided volume in children. But oxybutynine was not found superior than bladder retraining in decreasing the rate of incontinence in children. I summarize in the next 2 slides what we currently do for the management of overactive bladder in our service. We usually recommend urotherapy and constipation treatment for 6 months. And if there is no improvement, then you do at a minimum ultrasound post-void residual and referral to urology. If there is improvement, you don't need to refer to the specialist and you continue time voiding and PEG for 1 year. After this patient is seen by us in urology, we will do the uroflow plus or minus EMG, and we start the child with Solifacin or mirabegron, depending if there is constipation or not, or oxybutynine if we cannot get coverage with the patient's private insurance. And we optimize the medication over 6 weeks. Then if there is partial improvement or no response, we can optimize up to maximum dose. And if there is no improvement with that, we associate both medications. If that's not enough, that's when we consider neurostimulation or the Truser botox injection. If the patients are doing well on the medication regimen and on their, per optimal dose, we continue medication for 1 year before considering weaning off. The average time that patients need to be on either anticholinergics or mirabegron is 1 to 2 years. And for the dysfunctional voiding management, is the same, the initial management with urotherapy and constipation treatment for 6 months. If improvement, you continue bladder retraining and PEG for 1 year. If there is no improvement, ultrasound with post-void residual, referral to us, we do the same tests. But the difference is that the treatment will be biofeedback or pelvic floor physio instead of the medications. If we do that for 8 to 12 weeks, we assess the child. If there is partial or no response, we consider tonsilosine, which is an alpha blocker to help relax the external sphincter. And if there is full response, we continue medication associated with physiotherapy for 1 year. And if there is no response, we consider and discuss sphincter botox injection. So we talk a lot about PVR, but a common question is what is normal PVR in children or post-void residual? So the International Children's Continence Society, ICCS, suggests that for a child between ages 4 and 6, a single post-void residual of 30 mL or more than 20% of voided volume, or repetitive PVRs greater than 20 mL or 10% of the voided volume. And for older children, then will be similar to adults, a single PVR of 20 mL or repetitive PVRs of greater than 10 mL. Then I briefly would like to touch on other common types of voiding dysfunction that we see. They are also complex to manage, such as stress incontinence, which is the involuntary loss of urine during physical movement or activity. So any conditions that elevate the intra-abdominal pressure will cause leak in that instance. And it's common in adolescent competitive athletes and gymnasts. It's not related to psychological stress. And the first line of treatment, in addition to urotherapy and constipation management, will be Kegel exercises and pelvic floor physiotherapy. We do use the Anticholinergics as a second line of treatment, especially prior to activity. So it's worthwhile, for example, for a gymnast, a couple hours before her activity to take immediate release oxybutynine to help out not having an accident while working on pelvic floor physiotherapy. The other type of voiding dysfunction that I would like to discuss a little bit is Giggle Incontinence, which is rare but quite disturbing type of voiding dysfunction that typically occurs in young girls. And the pathogenesis is unclear, but likely has a central cause, and it's suggested being hereditary. So it's different than the stress incontinence, little leaks that the child has. The child has a involuntary complete bladder emptying only during laughing. And the first line of treatment will be bladder retraining, physio, and biofeedback. We can associate anticholinergics in refractory cases, and methylphenidate has been used as the third line of treatment, but it's extremely rare. I don't have any child on methylphenidate, but it's described. And lastly, Human syndrome, which is uncommon, but it's important to have that in mind and treat whenever we find it. So Human syndrome is the most severe type of dysfunctional voiding, and it works like and it behaves like a bladder outlet obstruction. It's although being rare, is more commonly found in patients with severe trauma, such as sexual abuse, PTSD, and those kids may present, after potty training at any time with incontinence, dribbling, abnormal stream, incomplete bladder emptying, retention, UTIs. And in the ultrasound, you see severe bilateral hydronephrosis, parenchymal thinning, hydrouterus, abnormal bladder. So you have on the right-hand side of the CUG of a patient with Human syndrome, and you see this trabeculated, Christmas tree type of bladder with severe bilateral grade 5 reflux that you would think that could be posterior valves in a boy, but usually with a normal urethra when they are scoped. They may have abnormal renal function, low compliance, and high blood pressures on urodynamics. The medical treatment is aggressive urotherapy, PEG, tonsilosine may be needed, and CICs. Because they sensate the urethra, and very commonly humans is seen in a context of severe trauma, they may benefit from mitrophanol for CICs or injection of botox to the external sphincter. And SNS may also be considered long-term, but because of the impact, immediate impact on renal function, it's important to start catheterizations as soon as possible in cases that do not respond to alpha blockers and conservative treatment. Bladder and bowel dysfunction is an extremely prevalent condition. We see approximately 3,000. We used to see prior to the network 3,000 cases per year at SickKids. It's 40% of all of our consults. So to deal with that, to provide timely and high quality care for those children in the community, we created the Bladder and bowel dysfunction at GTA. Initially, we had 7 sites. Now we are 11 sites with pediatricians, pediatric nephrologists, nurses, nurse practitioners, physician assistants, physiotherapists, and so on and so forth, which I'm very proud of being part of. That was it for the presentation, and I'm happy to answer any questions.
So Joana, I touched on it in the Q&A earlier, but
okay.
For case 1, the overactive bladder patient, someone asked about biofeedback and pelvic floor physio if he had those things.
So yeah, he had pelvic floor physio, not for the overactive bladder, as it does not really work well for it, but he had for the bowels and did not really work.
Okay, so another question, when you use the term urotherapy in treatment, does this mean time voiding other conservative measures besides treating the constipation, obviously?
Yes, yes, it does. So that means time avoiding Q2 hours, increased fluid intake, dietary changes for constipation and PEG.
Okay, and then someone says you don't use oxybutynine anymore?
No, I don't. I pretty much don't use unless the patient does not have coverage to start the medication, or if we don't have OHIP coverage for them.
Okay, it doesn't seem like there's any further questions. Oh, wait, we have more. So can you give us some advice on dosing alpha blockers in children?
Yeah, so we actually don't have clear guidelines, but my experience is for children weighing less than 15 kilos, you can start with 0.2 milligrams. With a maximum of 0.4 milligrams. So what I typically do is tonsilose in 0.2 milligrams once daily. And you try that for a couple of weeks. If no side effects, no flushing of the skin, lightheadedness, dizziness, then you increase the dose to 0.4 milligrams. And for children weighing more than 15 kilos, you can start with 0.4 milligrams with a maximum of 0.8 milligrams daily.
Okay, thanks. I have a question from Natasha. She wants to know about your experience with CIC for refractory BBD and what would be some indications for starting CIC for BBD?
Yeah, so thanks, Natasha. I would say that especially for children with upper tracts, effects. So if we have bilateral hydronephrosis as the Heman syndrome patients that did not respond to tonsilosine, and if injecting the sphincter is not an option, we do start them on CICs. It's tricky though, the same way as it's tricky for patients with posterior mitral valves because they sensate the urethra. So I have a few patients with severe dysfunctional void and Hemans that I needed to start on CICs. And the field that I have, we offered Mitrofanoff.
Okay, thanks, Joana. How long would you use oxybutynine before considering it ineffective and motivating other medications?
Right. So I usually start with any medications, oxybutynine, sulfenacin, mirabegron. We reassess in 6 weeks to see if there was any effect at all. And if there was not at 6 weeks, then we optimize the dose. Then after maximum dose in 3 months.
Okay, thank you. From Darius, have you thought about prevention strategies for this wildly prevalent condition, such as interface with schools or screening strategies?
Yes, we have thought about that, and maybe Abby can comment on that. We have been before COVID, and now we need to resume that. So we reach out to schools for education and prevention. You know, Darius, that one of the most common complaints that children have is that they don't like washrooms at school. So Abby had the idea of contacting the Toronto School Board to address that as standardized washrooms at schools and work with them to make it better. Abby, you want to comment on that?
Can you hear me?
Yes, we can.
Yeah, so because of COVID, what has happened is that the school's focus is mostly now on COVID strategy prevention. So they haven't really discussed any further on what to do, but I know that there are probably going to be more allowances for private bathrooms and to be able to encourage usage that way. But once COVID sort of settles down, I'll be chatting with the schools again to be able to figure that piece out.
Thanks, Abby. Joana, Armando wants to know that if you warn teenage boys about retrograde ejaculation with Flomax.
I do warn them, yes.
Okay, this next question, it says, what is the time that a pediatric surgeon in complex anorectal malformation can call a urologist to use the appendix for urologic procedures? So I guess that's when can you indicate a MACE?
When can we indicate a MACE? So for kids that are already optimized with medications, as in the case that we discussed today, an option instead of Peristeen of the retrograde enema would be a MACE, and we had a discussion at that time.
Okay, and then we can combine these two questions together. So when would a VCUG be indicated? And if you give antibiotic prophylaxis, how long do you continue it for?
So if you suspect, let's say, if you have a child with bladder and bowel dysfunction and recurrent urinary tract infections, despite optimized treatment, the child is better from BBD but continue to have recurrent UTIs, that will be an indication for VCUG to rule out reflux. Another indication for a VCUG will be a child with abnormal upper tracts, especially, let's say, a boy with bilateral hydronephrosis, abnormal bladder with incontinence. We should do a VCUG to rule out valves. So those are the major indications. Mandy, can you think about anything else?
No, I think those are the important ones. And then for how long to continue prophylaxis, I think that
go ahead.
Yeah, usually it would be for about 3 months. And so even if they're not true febrile UTIs, it's just more lower urinary tract symptoms, you can give prophylaxis for 3 months while they're working on fixing the underlying problems. And then we usually stop after that time.
Yeah, perfect. That's what I do as well.
Okay, and then so in South America, the options are limited. So what are the studies that you should consider to be done at a minimum?
Yeah, I think that an ultrasound with a measurement of post-void residual is a great initial study. All what you want to know is what is that child, bladder capacity, and you can get that from the voiding diary. And if there is a post-void residual, what you want to know if it's safe to start medication right now, and is medication indicated, right? Is this overactive bladder versus dysfunctional voiding? And you can get a lot of information with an ultrasound with post-void residual. Also, in refractory cases, it's important to get a spine MRI at some point to rule out neurogenic bladder.
Okay, so it seems like all of our questions for now. So I guess thank you everybody for joining us. It looks like we had a lot of attendance from all over the world. And so thanks for this great talk, Joana. And I think you did a great job. This should be available on our YouTube channel shortly, and then we can tweet out the link for that for anybody who wants to watch it afterwards.
That's great. Thanks, everyone. And if you guys have any further questions, feel free to reach out to us and send us an email, and we're happy to answer any questions. Okay. Thank you for joining us.